A lot of this is fresh in my mind. I'm recording this pretty much immediately after a virtual consult. And remember, it's a consult. I make it very, very clear that give an explanation for everything that we're talking about. But if that's not what they want to do, it's okay. We're looking for answers. I think I always fashion myself to be a problem solver, and we got to find answers. If those are not the answers that you want, I didn't do a good enough job to get future consulting opportunities. That's kind of how I look at consulting in general. So we always talk about, explain what I'm trying to accomplish in terms of my advice, which would be red lights, yellow lights, and green lights. Now, I think we know that for us watching and listening, those are not the correct terms. But again, you have to use terms, at least in my mind, that allow people to connect with the message. And then I'll say a red light, we're going to look at everything. We're going to integrate what you say, what you do. If we do have the truth in terms of imaging, red lights are not red lights forever. Maybe if you can see a green and then it changes red on your way up, you're going to be at that light for a minute. Sometimes you come up and you're coasting and all of a sudden it turns green right away. So different reds, though, these are not a good idea to do right now. And of course, you always explain why. Then we got the yellow lights. And yellow lights would be exercises, joint positions really that are part of exercises that probably okay to do, but maybe under certain circumstances. Maybe we don't do them explosively. Maybe we do them even under body weight, but we're still doing the full compound or type of exercise. Then you got the green lights where, hey, let's have a go at it. And we're really just basing primarily on if joints can get into the right positions to absorb adaptive stress. I think in these virtual types of situations where you don't have the opportunity to do a full keen movement evaluation, which would have active versus passive appraisals, if something's painful, you always kind of revert to a rehab for meatheads, where you find the heaviest load you can do. It's got to be 100% pain-free, so I just took a lot of wheels off the bar. We've got to do 20 to 100 reps, so we took a lot of wheels off the bar. And if necessary, we slow that movement down significantly. We might not have a lot of weight on the bar. And clearly for a lot of situations, we'll get into in this one, which was pull-ups, it's under body weight. And that is okay, because that is, we're taking an approach that if you can find the same exact pattern that's pain-free, then we are looking at a soft tissue limiting factor. This is not a joint limiting factor. Joints typically don't really care most of the time. Obviously, if it's compression and let's say something like the knee, you might find that this doesn't always hold up. If your standard is, you're not going to make anything worse and you're still going to deliver a training effect, the time under tension, as we've talked about with rehab for meatheads, or the more specific scientific protocols would primarily be affecting and attempting to create adaptations at the non-contractile elements of the muscle. You can't possibly be overloading the contractile elements of the muscle if the load is not heavy enough. It doesn't mean you're not training. And at some point when you start getting into significant repetitions, 50, 60, 100, this is not this meaningless, useless, effortless type of training approach. You are getting some things done. We get into those three categories, and then there's at least context for where we're going, because if somebody's, most of the time when someone's doing a virtual consult, there's a couple commonalities that I see. One is they're not happy with where they're at, and that's okay. Like, we found a gap in the market, somebody's going to pay me money in order to fill in their gap, and I think that's a very, very good thing. I do think that there's this expectation at times, at least to start, or at least before I create lots of context to the dialogue and the exchange, is like there's some kind of magical solution that I can, turn the camera off, turn it back on, and everything is good, and their shoulders and hips and everything moves in a great way, and they can, clean 4 wheels now. That's obviously not the case. So I need to be what I would often apologize for, depending on how the communication is going, that, hey, I'm being verbose here, because I want you to understand my perspective. Because if I do have to tell you something that you don't want to hear, at least you understand why, and you also know that you're not obliged to follow my instructions. No one is. You can go to the most baddest brain surgeon in New York City, and you are not obliged to follow his instructions. You may die. However, that's still your call. And clearly a lot of these situations where these are not inexperienced lifters, but they're inexperienced movers, and they have been failed miserably by whatever types of interventions, whether it was coaching, whether it was physical therapy, even if it was orthopedic care. They've been failed miserably in getting solutions or explanations for what it is that they're doing. So then when they try to get out of fourth gear or get out of fifth gear, all of a sudden they hit this brick wall, not because their understanding of what training or training form ideally should be. It's that their body doesn't support the choices that they're making. They just need to make different choices, and hopefully the horse is not out of the barn, or at least not out of the barn too far. And that's when it gets really difficult, because a lot of these times too, a commonality is that people can push through things, but they can't push through more things, or they can't push harder through the same things. And that's another solution that we're able to try to create. Be like, no, what if you do this instead? It's the same muscles, and most of the time that is not received in a negative way. You're kind of trying to paint the picture of what we're really trying to accomplish here. And with this individual, he talked about his shoulders. He said he's been told his shoulders were lax. I'm like, okay, eye roll. But primarily, he says he's got this history of shoulders, the right side worse than the left. He said he had a rotator cuff tear, probably either asymptomatic or certainly not significant on the right side. He also said from doing a lot of pull-ups, it then became clear that he was training with a lot of cross-stretch strategies, which isn't that big of a problem in this case. He has medial elbow pain from doing pull-ups. Okay, so that's clearly something we'll typically see when shoulders either don't externally rotate or we struggle to stabilize in external rotation. It was actually very clear with his back pain that his back will either not perform well, his strength of his legs will be very limited in deeper triple flexion, meaning hip flexion, knee flexion. He described getting up on a surfboard out of what I would say out of the hole. I don't know if there's a different word in surfing. He says, I feel like I have no leg drive when I get up on the board to start to take the wave. And other types of exercises where he would then describe anterior hip pain. And I'm like, okay, check. Again, I'm listening. I'm trying to not lead on to any of my body language. I'm sure I'm not immune to failing at that, just like we all are. But again, now we're talking very typical stuff here. I already kind of have an idea. He went on to say, yeah, I do hip mobility. I don't know what that means, but he's doing something, and it doesn't change. I said, well, where do you feel this primarily in your hips? He's like, right in the joint. As I said, is it, and I let him on, no question. Is that like in your underwear line? And he's like, yeah, but it's also here. I said, but it's always in the front. I said, I understand. Okay. Talked about history of lower body, knee tendinopathy, ankle sprains, plantar fasciitis, but none of those things were primary at the moment. Remember, he said his right shoulder was the one that was more buggy, bigger history with that rotator cuff issue, never handled it. Holding the little guy, elbow pain. Okay, all right. At some point, as we enumerated this before we went into whatever movement analysis we were going to do, hey, unless Triple H hit you with the sledgehammer in the elbow, I would say 90+%, if not more, of your elbow issues are dealt with, are problems in the shoulder girdle. Especially what we saw with the pull-ups. Lastly, he talked about, and he used this term TFCC. He did point to here though, but it was really up here, and that's where, again, I'm glad that he had at least that. And that was actually, his symptoms probably fit into the category. There's stuff he can go through. But then when he talked about some of the fighting, some of the bag work and some of the boxing or striking training, where it really would hurt, I said, listen, that's a normal activity and you're getting a significantly abnormal response. Let's see where that lands here. But the likelihood that I'm going to just say, don't worry about it, talked about extension. You might need to do push-ups, on handles or dumbbells, whatever those things may be. But also, man, like that shoulder might be, because it was the right side. So you've got medial elbow, you got global elbow, you got right shoulder, you got this now TFCC. He also had some symptoms through the thenar eminence here on the palmar side. And he said he was also tested for carpal tunnel. I'm like, well, it's interesting because if whatever was happening at the TFCC was so swollen, I guess, or creating this inflammatory response that did temporarily fill up the carpal tunnel, I guess you could have some of this branch. I'd have to look up what the name of it is. It may be a little bit of median, not likely to be a lot of radial. But he never really had the traditional carpal tunnel syndrome symptoms through the fingers or weakness or anything like this at the tunnel, at that carpal tunnel. So I said, you're probably hiding from whatever extension position that makes this TFCC angry, and you kind of change how you, he's like, yeah, like it hurts a lot here when I'm on the rings. I said, did it always do that? He's like, not really. Okay, so my guess, and I say this all the time too, it's like, hey, listen, I'm just storytelling. But that's what these calls are about. They're about answers. It's about giving somebody a perspective, and then what they do with it, at least the next time they see somebody else, they're going into that conversation a little bit more empowered, a little bit more knowledgeable, just like I need to be when I bring the truck into the dealership. I know nothing about the vehicle. If I know more, at least I can call them out when they're trying to sell me a flux capacitor. That one they're not going to get me on, even if I'm going 88 miles per hour. So we've got the wrist, we've got the shoulders, and we got the hips, low back. It's clear that that's going to be the same construct. So touches toes, awesome. You know, almost getting wrists to the floor, but he has opening joint pain. He called it pain. He's like, yeah, I got something here. It wasn't just hamstring tension. And of course, it's okay to have hamstring tension when you're getting all the way down. It's okay to have hamstring tension anytime you touch your toes. Because if you call it pain, or you call it tension, or you call it tightness, whatever it is, we kind of have an idea of what's happening at the joint. So probably not that big of a deal yet. Backward bending. Pain in the same spot off to the left side. But he's kind of drawing a line. Maybe it's 4-5, maybe it's 5-1. Obviously, that's irresponsible for me to suggest from a virtual type of setting, but where he's pointing as well. And arms overhead, backward bend, pain, doesn't move very well in terms of excursion that I would like to see. For backward bending, I'd like to see the ASIS get in front of the toes. I'd like to see the scapula get behind the heels. I'd like to see a uniform spinal curve. And I'd like to see the hands get past the scapula. This is all from SFMA 101. I'm pretty sure he didn't have any of those, which is okay. You're allowed to be tight, but he had pain there. Now, if you deload one leg, pain goes away, but he lost a lot of motion. Deload the other leg, pain goes away. So I'm not as concerned about an active pathology in the spine, but I am concerned about these global and/or aggressive training positions with arms overhead and looking to engage through the hips. You know, whether you have a bar on your back, whether you're pressing, pull-ups, all these things, they're starting to add up. I don't know if it's going north-south or south-north, but we just have two movements and we're already linking lots of things of what this gentleman said. Twisting was all wonky, all sorts of wonky. It wasn't really that limited as far as what you've seen in the past, but everything was different. He would change how where there's no, you can't say left internal, right external. There was nothing like, it was just all weird. I'm like, okay, making sense. Even though I'm not getting a clear clue there, I'm starting to think that the hips are probably retroverted. Because remember, everything that we're going to do in the SFMA was with feet together, and I didn't ask, but again, made the assumption that a lot of his lower body training, like surfing, is with toes straight. And single leg stance didn't learn much. Deep squat learned a lot, okay? He actually broke parallel, but had pain in both anterior hips. Holding on to something to get more anterior weight shift, less pain, but couldn't get up. So there is a dorsiflexion component to this. Through later conversation, he said, yeah, people will say that my feet pronate. And like, listen, it's all part of it, but clearly an opportunity to create a forward weight shift of the knee appearing to go over the toes can happen from pronated midfoot and tibial rotation. So if you can't bring your knee over your toe because you're lacking dorsiflexion with a neutral foot, you can create that illusion by getting the foot to drop. And again, at that point, we may find that the foot is driving the hip, which is driving the back. I think the shoulder is probably something different. Then when we looked at the shoulders, left side, okay, both sides. Right side doesn't go up his back very well. And then it did go behind his head very well, but he had right-sided trap pain, all right? Then cervical, no problem forward, no problem back, no problem to the left. Again, same-sided, right-sided trap pain. So turn right, feel right, okay? That's an issue. That could lead us to something. And again, if we were in person or doing a more proper physical therapy exam, we'd look at quadrant, we'd look at some side gliding, etc. And those could lead you to a snap, crackle, and pop that creates the same solution that we saw with this deload, and then all of a sudden neck pain or the trap pain gone. So we know that that right shoulder is hanging a little bit, creating some tension. I'm not sure exactly what to do about that from this virtual type of setting, but I know that his neck is not the issue. I'm not even sure the thoracic spine is a huge component here yet. So there's lots of gaps that'll still be in play, particularly when you have multiple priorities. So it turns out his hips do present as a retroverted. It turns out that when you bring his feet to shoulder widths and let him turn them out a little bit at his druthers, less anterior hip pain. I said bring them out wider and turn your feet out more. He buries, stays up tall, perfect looking form. Feet don't even really look that pronated, even though I can't see perfectly through the screen. And he dunks it, and he's like this far off the mat. Really great motion. I say, yeah, you have describing retroversion. So now, when it comes to retroversion and antiversion, which is really the crux here, I don't know that that's a problem. I think the problem is not knowing that you have it. Because yeah, there's probably some things that you're not going to be really good at, and if you keep trying, you then might get worse at it. So he talked about seated Z position, that you might kind of mobilize glute minimus on the front side, hip internal rotation on the back. I said, yeah, you're not very good at that. He's like, no. I said, you might not get better. You might have to sit up on some things and to be able to deliver that because of the position of the pelvis. But if you're insisting on doing lots of things relatively feet closer and relatively toes straight, you're going to have to arch in your back, and you're creating a lot of, in essence, what I would say clobbering L5S1 and L4L5. But by opening some space there, all you have to do is just put your legs out, because a retroverted hip is one that is at rest naturally, if you will, twisted outwards. You live in external rotation. It's why some people are going to be really, really good at wide stance box squat, and other people may be better at narrow stance Olympic lifting, just based on the shapes of their hips. And we've been seeing and hearing very credible messages ad nauseum that everybody has a different hip, and there's probably some type of stereotypical hip of individuals that have lineage from different parts of the world. People have different hips genetically, and different hips allow you to do different things really, really well. To not know that this is in play is how you get to this stage. And what I can't tell is if the ankles are driving that north, or maybe it's not as retroverted, but he has the same FAI symptoms as somebody who would be retroverted that kept their feet straight, because he doesn't have great dorsiflexion, because he turns instead of turning his feet out and then dropping in, he probably drops them in this way. And that probably extended beyond what we're typically trying to accomplish on day one in these types of virtual sessions. So I said that I was being honest, like, I don't know 100% here where we're at with this retroversion. You appear to be retroverted, but what I do know is that you appear to perform much, much better with your feet wider and toes out than might have been leading. But again, I'm giving somewhat of an assessment, bad word here, but I'm giving my opinion. But then he said, yeah, like, when I do sumo, I feel better, so I should do that. I said, I'm not saying, I don't know yet what you should do. I said, we're just kind of laying all these Lego bricks out on the table, and we're going to put it back together. I do know that there's going to be some things you're going to be really, really good at today. It remains to be seen how much better we can get at those other things. So as we fill in, we're looking to make those yellow lights green. We're looking to make the red lights yellow, and then the yellows green. And you just wind up with, access to more books in the Library of Congress. So that's two things to describe a little bit of what I think can be accomplished in an advice-only type of situation, where it's not a physical therapy evaluation. It's not possible to do that. Again, if somebody says it is, I don't know how. You're going to do certain special tests. It doesn't mean you can't create really, really good results, but it's not, you can't do passive, you can't palpate, I don't know. But you can really get some good information if you know what you're doing in terms of what some of these typical presentations of tests mean, and then you hedge. And you make sure that my language is clear as day, that this is storytelling. There's a lot more that I would do to confirm, including imaging. But I said, how about we just, if you're going to do any type of squatting or deadlifting, your feet have to be a little bit wider than you think, and they have to be turned out a little bit. There obviously is rock and lock. For any given of a width of foot position, you kind of fall back. Before you fall, you tighten your bottom and wherever your feet go. You can also put booties on and slide this. We're going to plug in some ankle dorsiflexion, and that in itself should be part and parcel to whatever changes. I don't know that hip extension is going to improve with toes straight, heels down, feet together. I don't know that it'll improve, but I know we can relax the tissue if we're using some proper methods. Maybe he'll have better hip extension somewhere else, to the point that he does not feel as needed to arch hard. He's like, yeah, people tell me to arch. I say, yeah, I'm sure you do. The shoulder, do I need the shoulder image? I don't think so, but we're going to run rehab for meatheads. We are going to use dumbbells and not a barbell. One shoulder goes up like the back this way, the other one's like this. Both have anterior shoulder pain with medial rotation extension. That should tell us it's probably a tendon issue, certainly could be a labrum. And we're going to run rehab for meatheads, with global movements. If I continue to work with this individual, we may go selective, with other types of rotator cuff tendon approaches, isometrics, positions, etc. But I think we should use kettlebells and dumbbells. I can't tell him to not go overhead. That wasn't his issue. So you can still have that medial elbow pain, but specific to the pull-ups, which was a big part of what he was describing. Listen, we might need to put a band around your foot, not because you're weak. It's not because your deltoids and your pecs and your lats are weak. It's whatever you're doing to overload the whole system, certain tissues are overloading. So I need you to get it as light as possible and then just bang them out. 40 reps. And what are you accomplishing? You're building up the weakest link. So that's where we enter lower than body weight. And I think that would make sense, because if your elbows and shoulders don't hurt during or after, hey, something good happened, and that something good is a primary standard to this level of training. Clearly, when you're preparing for an event or a sport or something, you're going to deal with less than 100 in, 100 out in terms of your effort to return. But that's not what this is. This is general population, and here's an individual that has struggled to meet other types of aesthetic or fitness related goals because his body keeps saying no. And we're going to dance and we're going to coerce these different movements. And in this case, because at least his shoulders do have the mobility, the shoulders can get into the right positions to absorb adaptive stress. I'm not going to say that kipping pull-ups and looking like a salamander is what loaded up these shoulders. I'm sure it didn't help. But it's only one side and not the other. I think a lot of people know I have zero affinity to a categorized response to having a problem on one side and not the other. I think that's a bunch of hooey, because we only remember the ones that fit the construct, and no one ever seems to talk about the ones that don't fit the construct, or you just name it something else. Like you're so far off the scale that it had to be the other side. No. Whatever it is, we're gonna fill in the gaps. We're gonna look at things in a very clear fashion. And I have every reason to believe, not only did I assure him that none of this was weird, none of this was nothing that anybody's seen before, he might find that there's going to be some exercises that are probably not going to be a good idea for at least a couple months. But then I went on to say, if all you had was a kettlebell, you do a kettlebell swing, which I believe he can do when coached correctly, and not lift the thing all the way over his head, I think you would certainly look the part when you do a lot of other really, really good things in terms of sleep, nutrition, etc. So that's a case study, but also how you can compartmentalize certain goals and be okay with being incomplete, because remember, it's kind of, you get what you pay for. But you can still really be borderline conservative, because if you do believe in the intensity that you can, of the things you can do well, then we can certainly get a significant fitness effect.